Looks like the waiting room is opened. People are coming in. Good to see everyone.
You can start, Dr. Singh.
All right, thank you so much. Good evening, everyone. I see a lot of familiar faces and names, so thank you all for joining us. All right, I think we'll get started. It is 5:01. All right, everyone, welcome to Spine Time. Today we have a very interesting talk on sacroiliac joint pain. If this is your first time joining us for Spine Time, this is a webinar that we put on through the Weill Cornell Center for Comprehensive Spine Care, just bringing you topics that we see a lot in the office that patients ask us questions on. And we wanted to host a largely informal meeting on this topic. The purpose of this is for you guys to ask us questions. So I'll be monitoring the chat the entire time. We have one of our experts here, one of our attending faculty physicians to help answer those questions, but please don't be shy. Type in the question in the chat window and we will try to get to all the questions as soon as we can. So just a little bit about us. We are the Weill Cornell Center for Comprehensive Spine Care, based currently in Midtown East with plans to expand throughout Manhattan. Basically, the purpose of our center is to provide a multidisciplinary experience to the patients, focusing on rehabilitation, pain medicine, neurology, of course, spine surgery, but then also using integrative techniques such as mindfulness, acupuncture, complementary medicine. The goal is really to optimize your function, to minimize your pain, get you moving as best as we know how to do so you can live a full life with those around you. Today, I am thrilled to invite one of my colleagues, Dr. Jennifer Soo Hoo. Dr. Soo Hoo is an assistant professor in the Department of Rehabilitation Medicine and the medical director of adult sports medicine. She's also the associate sports fellowship director, soon to be the official sports fellowship director for Weill Cornell Sports Medicine and Rehab. I know many of you were expecting to see Dr. Fu on this webinar, but unfortunately you have me. I will be filling in for him to hopefully answer some of the interventional questions, non-surgical, but if there are surgical questions, we can certainly try to address those as well. So without further delay, let me introduce Dr. Jennifer Soo Hoo. Go ahead, take it away.
Hi, thank you, Dr. Singh. Hi, everyone. It's a pleasure to speak to you all today about this topic. SI joint pain can be a quite difficult thing to identify and treat, and so hopefully our talk today can help clarify a few things. So to first start out, it's really important to understand where the sacroiliac joint lies and what its function is. So basically, it's the joint that connects the pelvis to the spine and lies specifically between the sacrum and the ilium bones of the pelvis, as you can see here in this diagram. It's also the largest joint in the body, and its function is to primarily provide stability and function as a shock absorber and transfer the load between the spine and the lower extremities. Because its primary function is stability, it's a very stiff joint and has minimal motion across it, which in contrast to, say, for example, the shoulder joint, which has a lot of mobility, but it is inherently one of the lesser stable joints in the body. Can you go to the next slide? Thank you. So about 15 to 30% of low back pain can be attributed to dysfunction of this SI joint. It's most commonly seen in either the elderly population as well as in the young active individual. It's also often misdiagnosed for other types of low back pain. And what makes it unique is that it has both an intra-articular and extra-articular portion of the joint, and both of these can cause pain. And as you can see in this diagram, it has a lot of ligaments that surround the joint that can also be pain generators. And then the other interesting thing is that there aren't really any muscles that control the SI joint's function, despite having a lot of muscles that attach to a lot of the bones that make it up. Next slide, please. So main causes of SI joint pain can be basically divided into two categories. So first, traumatic, which basically is abnormal stress on normal tissue, and then atraumatic, normal stress on abnormal tissue. So in the traumatic category, you basically can have pain that can be caused by a direct shear force to the SI joint to cause dysfunction, such as like falling straight onto your buttock or a rear end motor vehicle collision. It can also be caused by having a pelvic ring fracture, which then just causes stress to come more into the SI joint, as well as certain sports that tend to have a lot of repetitive shear forces across the SI joint, such as figure skating, golf, and bowling. And then on the atraumatic side, common causes include if you have some type of systemic inflammatory disease, most commonly ankylosing spondylitis, you can develop osteoarthritis in this joint. People who are, especially in the second and third trimester of pregnancy, can develop a lot of SI joint dysfunction. And then if you previously had a lumbar fusion, this increases stress of the SI joint and can cause pain here. So SI joint, and I know this is one of the questions in the chat, SI joint pain can be variable and can present differently in each person. Most commonly, people will present with low back pain that may radiate into the mid or upper buttock. It's also quite common to have pain coming down the back of the leg, kind of almost like in a sciatic-like pattern. As you can see in this figure on the right here that was taken for a paper that really studied common referral patterns from SI joint pain, you can really see that it's most commonly in kind of the posterior buttock and down the posterior leg. But you can also have people that can get it in kind of their inner thigh and their lateral knee. And I've also seen it rarely going all the way down into the foot. Pain is often worse with sitting, laying on that affected side, or movements such as climbing stairs. And usually there is a specific inciting event or new activity that can lead to a flare in these symptoms. So how is this diagnosed? So it's often difficult to diagnose this. There's no single physical exam maneuver that can identify SI joint dysfunction. Usually your physician will use a combination of history, and then if you have 3 positive physical exam maneuvers, that can help increase the diagnostic accuracy. Getting additional imaging studies can help rule out other possible sources of pain, but there is no set imaging study that has been found to be accurate in diagnosing SI joint pain. The gold standard for diagnosing this would be your physician doing a diagnostic injection into the SI joint with using an anesthetic such as lidocaine. And if your pain is relieved for the duration of the lidocaine, then that is considered positive, and then that is pointing towards the SI joint being the cause of your pain. Next slide. So, and Dr. Singh will talk a little bit more about interventional management, but I just wanted to touch a little bit on the conservative management. So treatment for this pain usually starts out conservatively. So I have a list of different things that can be helpful depending on what is causing your SI joint pain. So an SI joint belt, or a Sacroiliac belt is what it's called, can help stabilize the joint and when you wear it with movement, and it basically helps kind of force close the SI joint and can be especially helpful during pregnancy. Anti-inflammatories such as NSAIDs, discuss this with your physician, but if you have an inflammatory component of your SI joint pain, this can be helpful. Modifying your activities, so modifying the activities that are causing this pain is really helpful to kind of decrease stress and inflammation coming across that joint, and then not returning to those activities until you're a little bit more pain-free and stronger. Kinesiotape has been something that some studies have shown to be helpful, and usually your physical therapist can help you with this. Orthotics is also something, if you have an anatomical leg length discrepancy, then fixing that can help decrease the stress along the SI joint. The thing to note is that if you have a functional leg length discrepancy, which is basically a leg length discrepancy caused by just abnormal biomechanics, that should not be corrected with an orthotic, and that's something you should definitely bring up to your physician and talk over in more detail before just going out and getting an orthotic. And then physical therapy, which is the main best long-term solution. So the whole goal of physical therapy is to restore the natural motion of your joint and help strengthen the surrounding muscles and ligaments to better support the joint.
Before going to interventions, there's a lot of good questions coming through the chat, so I just wanted to pick your brain a little bit. You showed a slide earlier about the SI joint being predominantly a joint connected by ligaments, and not many muscles around the joint that provide motion or cause motion to the joint. And there's 2 schools of thought. Some suggest that the SI joint never moves. You would probably fracture your sacral bone or your iliac bone before the joint actually shows some mobility. what are your thoughts on that? Do you find that there is actually true SI joint mobility that's normal? And at what point do you say, you know what, this motion is not abnormal, we actually need to intervene and fix that?
So, that's a good question. And I think that's going to be a little bit different in everyone. The majority of papers show that there's at least like a 4 to 6 degree movement that is considered normal across the SI joint. And then people who are hypermobile are going to have more movements because they're going to have more laxity on the stabilizing ligaments. And so they tend to be more mobile across the joint there. The whole idea that, abnormal like movement basically comes at the, you basically decrease stability when you have abnormal movement. So the whole idea is to just basically help stabilize with the physical therapy and some of the other interventions that you may talk about.
Someone mentioned in the chat about Ehlers-Danlos syndrome, and this is a condition in patients who are hyper lax. The ligaments and some of the tendons are very, very loose. One of the more famous actors out there, Jim Carrey, he has Ehlers-Danlos, and you can see when he makes his facial expressions, he can move his face and his mouth and muscles in various ways that other people cannot. And we have seen that patients with this condition, Ehlers-Danlos, do tend to get ligamentous instability around the SI joint. So I don't know have you seen patients with this condition suffering from SI joint pain, and what are some of the things you may recommend for them specifically?
Yeah, so obviously having Ehlers-Danlos syndrome is tough because that's not something that we can reverse or change. I definitely have patients with Ehlers-Danlos who come in and have laxity in basically all their joints, SOA joint included. And basically, what I tell them is, we can't change the intrinsic laxity of their ligaments, with anything. And so the best thing is to basically work with a physical therapist that is familiar with Ehlers-Danlos syndrome, and then make sure you get a set home exercise program that you can incorporate in your daily life to keep all of the muscles and ligaments stable to help protect the SI joint. And so you can kind of go on and living your life with decreased pain. And then, it may be modifying your life a little bit. So avoiding some of the specific exercises or activities that where you have to stand on one leg a lot or and then, as I said, figure skating, bowling, some of those other exercises may be something that you want to, pull back or avoid. And then SI joint belts can be helpful, especially during a flare up, to help kind of just stabilize that joint.
Excellent. PT, you kind of talked about PT.
Yeah.
I wanted to touch on interventions and then go back to some of the questions that, some of our guests are having. So regarding interventional approaches, the goal for intervention, just like Dr. Soo Hoo mentioned, is pain management. And I tell everyone that. I see a lot of my patients on this webinar today. I always say, listen, I'm not going to fix you with this injection. I am going to help your pain so that you can do the necessary things to fix the problem, which is exercise and rehabilitation and some of the mechanical work to strengthen the joint. So one of the ways sacroiliac joint can help is with the diagnosis. If you put lidocaine into the joint and that provides relief, then you know that that's where the pain is coming from. And rarely do we like to use steroids inside the joint because very rarely is this an inflammatory problem. Now, there are patients who have rheumatologic conditions who get something called sacroiliitis, which is actually inflammation of the joint. They respond very well to that injection, but that's rarely the case. But once you diagnose that the SI joint is the source of the pain, another intervention that we can offer is something called a radio frequency ablation. And I have done this to some of you on this webinar. And basically, I'm finding the nerves that cause your pain and turning them off. Again, I'm not providing stability to the joint. I'm not making the joint any stronger. I'm just getting rid of the nerves to the joint so that the pain is less, and then you can participate in rehabilitation and some of the physical therapies that Dr. Soo Hoo mentioned. One of the interesting things that we've been investigating and looking at is regenerative options like stem cells. Technically the word stem cells is not correct, but basically, we all have these stem cells floating in our body. Whenever we get cut, our cells come to the area to form a blood clot, and then our tissue repairs. Same thing in joints, same thing in tendons, same thing in ligaments. And one of the tools that we use is something called PRP, platelet-rich plasma. where we take blood from your own body, we spin it down, we concentrate it, and we inject those growth factors, those proteins back into the joint to provide some stability. We've had actually decent success in patients with Ehlers-Danlos to target the ligaments around the SI joint. Because remember, we talked about laxity of the joint is causing the problem. So if we can stabilize those ligaments, cause less pain, hopefully that patient can participate in most of those activities. One of the questions that keeps coming up is post-fusion. In lumbar spine surgery and in cervical spine surgery, once you have a fusion, the forces that used to go through each segment no longer can. So they have to go around this whole construct. And if you're fused at the bottom of your lumbar spine, which is L5 and S1, the next joint adjacent to that segment is your sacroiliac joint. So it's very, very common. And after an L5-S1 fusion, we see patients develop sacroiliac joint pain because now that joint takes on more motion. One of the questions that came up is, what maneuvers should I avoid? You mentioned trying to avoid certain maneuvers that could make it hurt, such as bowling or ice skating or things like that. What have you seen in your practice? What do patients tend to do that cause worsening pain of this joint?
So, I mean, I think it's a little bit different, with everybody, and everyone has a little bit different biomechanics. The slide that we skipped, there are certain muscles that tend to be weaker in certain people, which then also increase the amount of motion through the joint. So, identifying that and strengthening that will be helpful. In terms of other specific movements, it's basically anything that causes a lot of force to go from your lower body through your spine to your upper body. So it's forceful movements, like when you bowl, you think about you're forcefully throwing, and you kind of sometimes throw your leg behind you, and there's a lot of force that's transmitted. So it's basically any movement that just forcefully puts force from basically going from one part of your body through basically your torso, your pelvis into your lower body, or vice versa.
I'll say, one of the common questions that we ask patients, especially when we're training medical students, residents, and fellows, and we always want them to ask this question, is what makes the pain worse? And typically, if while you're sitting, you tend to feel okay, but then you transition from sitting to standing and you have pain and you start walking it off and the pain goes better. I mean, that's very classic for a sacroiliac joint dysfunction. Because just like what Dr. Soo Hoo mentioned, you're transitioning the forces from sitting to standing, and all those forces have to go through somewhere, and usually they go through that hip joint, from the hip joint into the sacroiliac joint. I had SI joint pain. I pretend to be a golfer sometimes, and that rotational movement, I knew it was SI because when I was sitting there seeing patients or writing notes, I was fine. But as soon as I stand up and see the next patient in the next room, I would have severe pain, walk 10 steps, and it would go away. So that's kind of one of the hallmark signs that you can imagine if you're trying to diagnose yourself at home to see if your pain is actually coming from the SI joint or other areas. Someone asked about sacroiliac joint fusion, and I'll comment on that. Dr. Fu was supposed to be here as our neurosurgery colleague who does this procedure. But basically, once we've confirmed that the pain is coming from the SI joint, we've done the conservative options, wearing the belt, strengthening the muscles, going through some of the interventions that I mentioned, which can help temporarily. Yet the pain still comes back and there's still some micro instability of the joint. That's an indication to do a fusion of the joint. And there are some patients on this webinar that I know have had that fusion surgery, and now there are actually more minimally invasive options to fuse that joint. And it's very easy. So someone asked, who knows a great, amazing doctor for fusions? Dr. Fu at Weill Cornell, he can certainly address those conditions, but it's an outpatient surgery. They put some hardware into the joint, which stabilizes it. And that's not the end of the game. After that, you do have to go back and do rehabilitation and strengthen the muscles, or the fusion could fail. So remember, especially Dr. Soo and I, we're physiatrists, we're physical medicine rehabilitation doctors. We practice and preach rehab, but we have interventions at our disposal to help pain. What else do you tell patients, Dr. Soo Hoo? They say, I want to go play with my kids, or I want to garden, or I want to tennis. Yet, I have SI joint pain. You've diagnosed it. What are the chances I can go back to doing these activities?
Yeah, so it also depends a little bit structurally and kind of what's causing this. If they have some arthritis, if they have an underlying systemic inflammatory condition, you want to tailor the treatment program depending on what is causing their SI joint pain. But honestly, the majority of people, if they're really good about modifying their activity to avoid creating inflammation or stress across the joint, and then doing a really good physical therapy program and strengthening kind of the muscles around the SI joint, they're able to then to kind of slowly get back into those activities. Again, as we discussed a little earlier, if you have some underlying, condition where you just are more loose jointed and you just have increased laxity around the joint, sometimes there may be a little bit of a limit of where we can get you back to. But for the far majority, with a good physical therapy plan and good modifying your activity, you can get there.
One of the questions that a few people have asked in the chat is about sleep. And we see this a lot in spine pain in general. That's, during the nighttime when patients are trying to sleep, that's when they experience pain the most. A lot of that is due to what we're taking in at the time from a sensory standpoint. We're not eating, we're not tasting, we're not listening or watching anything. So our brain is focused on where there is pathology, and usually patients with neuropathy or sciatica or things like that can feel that a little bit more at nighttime. But tell us specifically about sacroiliac joint pain and sleep. I have a lot of patients that say, when I do something in bed, it hurts. Can you comment on why you think that might happen, and what are some recommendations you offer patients to sleep in the best position possible?
Yeah, so I mean, the classic presentation at sleep with SI joint pain is laying on the side that has the SI joint pain. So the biggest thing you can do is avoid laying on that side, because when you're laying on that side, you're just increasing, some stress through that joint. So trying to, lay on the other side, if that side not symptomatic, laying on your back can be really helpful. If there's a kind of psychological component where you don't have anything else, that can kind of take your mind off of it. Sometimes changing positions may not help quite as much. But if it's more about the pressure through the joint, it's getting off the side that has the pain. Sometimes people also like putting a pillow between their leg to kind of help get the body in a more anatomical position. That could be helpful. And then also just making sure like your bed is has a good supportive mattress and isn't too soft or too hard.
That comes up a lot. What type of pillow should I sleep on? What type of mattress should I sleep on? And there've been studies, and we've kind of investigated that here on what mattresses can help what patients. The data is kind of mixed on that. Basically, what we have found, though, is exactly what you said: something with some stability, some support. I prefer the memory foam over the coil mattresses and medium firm or firmer mattress, just because when you sleep in a slump position, you're going to wake up stiff, you're going to wake up kind of convoluted. So sleeping with something that provides you stability is always a little bit better. And speaking about the epidemiology of sacroiliac joint pain, when you look at your whole practice, what is kind of the demographic of patient that get SI joint pain? Is this a young person, athlete playing soccer and stuff? Is this an elder adult playing with their grandkids or racket sports? Who are these patients?
Yeah, so there's kind of two groups that it has kind of like a bimodal distribution. So you have your, so it can happen kind of in the older population, and that's where you're kind of seeing like more commonly people having osteoarthritis there, or if they've had a prior lumbar fusion causing pain through there, or they've picked up, bowling or golf. That type of thing, I can see it more there. And then you also can have it in the younger population. And that tends to be a little bit of the more traumatic causes. I see this a lot more like with people like falling down their stairs and landing straight on their buttock, more vehicle crashes. Pregnancy, I see it a ton. It's very, very common in people who are pregnant. And then sometimes systemic inflammatory diseases are discovered in your kind of 20s and 30s. And sometimes it presents just first as kind of this weird low back buttock pain, and that just kind of happened out of nowhere. And then that can be an early sign of some type of systemic inflammatory disease that you would need further workup for.
Talk to us a little bit about pregnancy and sacroiliac joint pain. A couple of weeks ago, one of our co-attendings, Dr. Jacqueline Bonder, who's the head of women's health and pelvic pain here, her and I sat down and talked about specifically back pain and SI joint pain in pregnancy. Talk to us a little bit about that. Why do you think that happens? Why does that happen? And what are some of the treatment options we can offer those patients?
Yeah, so when you're pregnant, your body releases a hormone called relaxin, which basically just like relaxes all of the ligaments in your body. And so, as you saw by that prior picture, you have a lot of ligaments surrounding your SI joint. And so, when that happens, instead of those ligaments providing stability, they're a little bit more relaxed and can allow more movement coming across the joint. In addition to that hormone, you're also, getting a bigger belly, which is kind of changing the biomechanics of your pelvis. You're arching your back a little bit more. You're having more weight pulling forwards. Your core strength is decreasing because your belly is getting bigger. So you have all of these other stabilizing factors, in addition to the relaxin that used to help stabilize your SI joint that no longer are doing so. And therefore, like normal movements, just like going from sitting to standing or even walking sometimes can cause quite a lot of pain in that buttock area, and it's very common. And so getting the SI joint, there's not a whole lot you can do in pregnancy because you obviously can't change the fact that you have this hormone circulating, or the fact that you're getting bigger when you're pregnant. But you can wear an SI joint belt, and you can do some good physical therapy to help manage you.
What is one of the weirdest presentations of SI joint pain that you've encountered in your practice? I'll tell you my story in a second as well. But I just know that SI joint presents all over the map. You kind of showed the referral pattern that's classically butt, maybe some thigh, but what's kind of one of the weirdest ones that you've seen in your practice?
I can't say that I've had any super weird ones come across my practice. I'm interested in hearing your story. I think, I have one person who had like pain that would radiate all the way down to their foot, had some numbness and tingling with it. And so everyone thought it was like this classic ridic, and it ended up being an SI joint pain, and it was just very atypically presenting. So I can't say that's like super abnormal, but that was abnormal from the classic presentation of SI joint pain.
Yeah, I think, my presentation is kind of the same. I saw a patient who had what we thought was sciatica. I'd seen a couple of other pain docs, had an epidural. MRI of the lumbar spine looked pretty normal. I couldn't see any nerve compression, so it was weird that they had radiating pain down the leg. And honestly, I tried an epidural as well because the presentation was so classic and no relief. And after doing some therapy and yoga, Pilates, which someone asked a question, we're going to talk about that in a second. I said, you know what, let's do an SI injection. So as I put the medicine into the SI joint, the patient said, I feel it going all the way down my leg into my big toe. And I looked at the resident and the fellow and I said, wow, this is a very rare presentation of SI joint pain, but that just goes to show you there's so many nerves in the pelvic cavity in front of the SI joint. So even a little bit of micromotion can cause dysfunction of the nerves going down into the foot. And that's why physical exam is so important. Listening to the patient is so important. What makes it better, what makes it worse. And that's how we get to the diagnosis and eventually the treatment. A few people have asked about Pilates and yoga. Can you comment a little bit about how you use these modalities to treat SI joint pain? Is one better than the other? And when do you decide which one to implement?
So Pilates and yoga are generally really good. There are a lot of different types of Pilates and yoga, and you can get into like acro yoga and hot yoga and all of these different things. But the best is probably kind of back to the kind of the basics of what Pilates and yoga are for. And if you're just using them for the basic stabilization and strengthening of your core, your pelvis, then those are going to be great maintenance tools. After, if you had a flare up and you do physical therapy, those will be great maintenance tools. The biggest things, if you need to modify in the meantime, if you're having a flare up, would be avoiding doing any kind of one-legged stance stuff. So like one-legged squats, one-legged balance exercises, those type of things. You want to do everything more two-legged, so you're equally distributing the stress and not putting it all across one SI joint. And then as you kind of calm it down and do PT, you can then get back to doing some of those things. But avoiding a lot of the one-legged and any kind of weird contorted positions you may end up doing with those yoga or Pilates.
Yeah, I totally agree with you. One of the treatments that I was undergoing when I had my SI joint pain was bird dog, which I tell a lot of patients to do, right? You're on all fours, like a tabletop. You extend one arm and the opposite leg. And every time I extended the leg, which kind of looked like a donkey kick, I would feel that SI joint snap back and forth, snap back and forth. It didn't hurt. It actually felt kind of good, but I knew I was causing more instability and I needed to isometrically strengthen my glutes. So instead of doing the donkey kick, I would just lie on my belly and extend my leg up. So I'm just really engaging the butt and the hamstring, and eventually my SI joint pain has gotten better. Someone asked, what if cortisone and ablation don't work? The biggest thing here is the diagnosis. And we talked about some of the physical exam maneuvers that help us narrow this down. But the gold standard to date is still a diagnostic lidocaine injection. And I think we as physicians need to do a better job to our patients to explain what that means. Did the injection work? Lidocaine, we've all been to a dentist and they've injected Novocaine or lidocaine into our mouth, and it works for a couple hours. And a lot of times when you come to the pain management doctor, we do similar procedures where we inject joints or muscles or ligaments or something with lidocaine to see if you get pain relief temporarily, a couple hours, maybe 1 hour. And if you get relief, then we have confirmed that this is your pain, and then we need to treat it. So if cortisone doesn't work, all that means is you don't have an inflammatory problem. If the ablation doesn't work, which gets a little more complicated, remember that picture that Dr. Soo Hoo showed you, and I'm going to go back and show everyone again. This guy right here. When we do the ablation, we can only do the ablation from the back side of the joint. So patients are on their belly and I'm injecting the back side. Look at all these structures on the front side of the joint in your pelvic cavity. Now, if these are the pain generators, unfortunately, we don't have a good intervention to target those joints or target those nerves because we have to go through the pelvis. So that's when strengthening the ligaments really comes into play. We diagnose it by putting the medicine in the joint because that goes to the front of the joint and the back, yet they don't respond to an ablation. Those patients are actually good candidates for fusion if it comes to that. But really we want to optimize the non-operative treatments like even PRP or physical therapy and some of the things that Dr. Soo mentioned, like belts, which we don't want to wear a lot of because then the muscles get used to wearing a belt and your muscles kind of atrophy. Any medication that you think help with sacroiliac joint pain that you've used in your practice and you see patients kind of come in and asking to be prescribed?
Not really. If they're having like a bad flare up, and I see this mostly in patients who have like an underlying like inflammatory spondyloarthropathy, then I'll put them on like a meloxicam or diclofenac, which is a prescription strength anti-inflammatory, and that for like 7 to 10 days, and that helps. But for example, osteoarthritis in SI joint pain that just kind of like comes and goes. There's no great medications that I have come across that have worked well for that.
Yeah, I agree. Very rarely is this an inflammatory problem, like I mentioned. In the few cases that it is inflammatory, in fact, I just reviewed an MRI today from a young woman, an MRI of the pelvis, which shows severe inflammation of the joint. And usually when I see that, I'm thinking something else underlying. So I'm actually going to refer her to one of our rheumatology colleagues to investigate. Is there some underlying pro-inflammatory situation going on in the body? And then those patients can respond to some of these autoimmune therapies, such as Stelara and Enbrel and things like that. But really want to rule that out first before I start putting needles in things, because that's not going to give her long-term solution. Great questions coming through the chat. I think we've addressed most of them. The key is strengthening the joint. I guess first is figuring out the diagnosis. Where is the pain coming from? And once we figure that out, we can start implementing some of these conservative non-interventional options, and then going to injections and even surgery if necessary. Anything else for our guest today, Dr. Soo Hoo? Things that no one asked, things that you want to share from your practice or expertise?
Nothing big. I think for PT and things to kind of focus on strengthening, most commonly, and there was a great paper by Heidi Prather who looks at this a lot, is really focusing on the hamstring, as well as the glutes are always something that you should focus on because they always seem to be weak in everyone, but it's really the hamstring tends to be a really big thing that you want to focus on strengthening, in addition to the lower abdominal muscles are the things you should most strengthen. Wonderful.
Thank you, Dr. Soo Hoo, for taking time out of your practice and speaking with us on sacroiliac joint pain. Thank you to all of our guests here on our webinar today. This webinar can be found on YouTube in our Spine Time webinar series. And please visit our website at comprehensivespine.weill-cornell.org. And it's a pleasure. We'll be here in 2 weeks again talking about spine and sports, I think in pediatrics, if I'm not wrong. So please try to tune in for that. Great questions today, very engaged audience. So we obviously appreciate that. It just makes our job much easier. It's a pleasure seeing all of you guys at the Spine Center and all of our other Cornell practices. And thank you to everyone. Good night for joining us. And remember, when it comes to your back, we've got your back here at the Weill Cornell Spine Center. Good night and take care of each other. Bye-bye.
Bye.